Hello, my name is Tomonozaki. I am the chair of board of DNDi Japan and vice dean and professor of Graduate School of Medicine at the University of Tokyo. Welcome to the 20th anniversary event of DNDi today. I sincerely thank you for attending this webinar. We, Drugs for Neglected Diseases Initiative, DNDi, is an international nonprofit organization. We aim at delivering new drugs to the people who are suffering from neglected tropical diseases, which are endemic mainly in low and middle income countries. DNDi has 8 global offices, and our office in Japan was established in 2009 as a non-profit organization. We, DNDi Japan, have been playing some important role in creating partnership with pharmaceutical industries and academia in Japan, in a close collaboration with World Health Organization and Ministry of Health in Japan and overseas. Our past success was largely attributable to a close partnership among industries, academia, and government. And our future success will, of course, depend upon future collaboration with you. As you saw in the introductory movie, we have been working very hard to deliver medicine to the people in endemic area who are suffering from NTDs. Although we have achieved some of our goals, we still have a lot to unachieved goals. And the neglected patients are still waiting for new drugs to be delivered. I want to take this opportunity to thank all of our partners in the past, in the present, and ask you for continuous collaboration with us. In case you are not very familiar with DNDi and its activity, we hope this webinar helps you better understand our mission. We have a broad range of activities from research and development of new medicine against NTDs to fundraising and advocacy. Please find your way to work with DNDi to deliver new medicine to the neglected patients. I thank you again for attending this webinar, and I hope you enjoy this.
Thank you, Professor Nozaki, to set the scene of the webinar and share his commitment to continue engaging Japanese partners for the mission of DNDi. Let me introduce Fumiko Hirabayashi, DNDi board member and first DNDi Japan head, to talk about the background DNDi and what we have achieved in Japan and with partners. After her presentation, I will continue to explain what we do and what we try to do with Japanese partners.
Thank you, Kaori. I'm Fumiko Hirabayashi. First of all, I'd like to extend my heartfelt gratitude to each of you for gracing us with your presence today and providing everyone with a concise overview and some historical context of DNDi. Please, slide, please. More than 2 decades ago, Medecins Sans Frontières, MSF, was facing the distressing reality of patients in the field. Patients are suffering and dying, but doctors could not treat them because safe and effective medicines were not available. The dire situation was often stemmed from the lack of research and development, R&D, for neglected diseases. This is an outcome of survey conducted during the period, illustrating the landscape of R&D for neglected diseases. Of the nearly 1,400 drugs developed between 1975 and 1999, only 1.1% addressed neglected diseases, which represented 12% of the global disease burden. R&D for neglected diseases was almost at a complete standstill, sometimes resulting in fatal consequences. One well-known example was human African trypanosomiasis, also known as sleeping sickness, where doctors could not help 25 to 30% of patients. It was not because the disease was incurable, but because the drugs doctors were giving to their patients were highly toxic and ineffective. In response to this unacceptable crisis, MSF dedicated a portion of the Nobel Peace Prize Award to exploring a new R&D model for developing drugs for neglected patients. This effort gave rise to the inception of Drugs for Neglected Diseases Initiative, DNDi, in 2003. Next slide, please. DNDi, which is a not-for-profit R&D organization, was jointly founded by MSF, the WHO, and 5 leading research institutes. Our primary focus lay in developing treatments for neglected diseases. Next slide, please. So what are neglected diseases? At DNDi, we define neglected diseases as those posing a threat to the health and livelihoods of the most vulnerable populations and for which there is no appropriate treatments. Presently, the neglected diseases that DNDi focuses on encompass neglected tropical diseases, NTDs, and viral diseases. NTDs are the 20 different conditions identified by the WHO, which predominantly affect regions with tropical and subtropical climates, impacting around 1.6 billion people worldwide. Next slide, please. What is the DNDi's R&D model? DNDi is a not-for-profit virtual R&D organization that has no laboratory or factory. To develop new drugs, DNDi adopted some pragmatic strategies. For example, conducting research and development based on partnerships, adopting a 3-track strategy to develop treatments on short-term, medium-term, and long-term projects. And lastly, setting up regional disease-specific platforms to conduct clinical trials in disease-endemic countries. Next slide, please. Oh, no, one slide before, please. Please return to the previous slide. Sorry. Thanks. This shows one significant milestone in our progress, which is the development of fexinidazole, the first oral treatment for sleeping sickness, now in use in the Democratic Republic of Congo. The success of fexinidazole was the result of collaboration among diverse partners, with DNDi acting as a catalyst by coordinating resources. Fexinidazole is also a repurposed compound that underwent clinical trials in the Democratic Republic of Congo, utilizing the sleeping sickness regional platform. Next slide, please. Through this R&D model, DNDi has successfully delivered 12 treatments for 6 diseases to date, with ongoing collaborations worldwide, including Japan. In Japan, in the year 2000, during the G8 summit in Okinawa and Kyushu, and later that December at the Okinawa International Conference on Infectious Diseases, Bernard Decoux, founder of DNDi, and then the executive director of MSF Campaign for Access to Essential Medicines, delivered a speech. This marked the first official occasion in Japan where the necessity of research and development for neglected diseases was discussed. Next slide, please. The actual partnership began with 2 collaborative academia research projects. The first collaboration was a screening project with the Kitasato Institute, and DNDi's drug discovery efforts were modeled after this drug discovery platform. Another collaboration was Tokyo University's Ascoflanon project, which was selected as one of the globally solicited projects during the establishment of DNDi. Since then, we have collaborated with numerous academic institutions and pharmaceutical companies in Japan. As we reflect on the past 20 years, we acknowledge the remarkable global changes and the sustainable contributions made by Japan. Unfortunately, I am unable to present each one individually, but some significant examples include, for instance, implementation of the first clinical trials for Chagas disease and mycetoma, and the provision of a large number of compound libraries. A drug discovery platform led by pharma was also established in collaboration with academia and research institutions. For capacity building, a regional drugs screening network was developed with 7 Asian countries, and a treatment research center for visceral leishmaniasis was established in Bangladesh. And last but not least, a major contribution from Japan was the establishment of the Global Health Innovative Technology Fund, GHIT Fund, for R&D into neglected diseases. I'd like to conclude my talk by expressing my deepest gratitude to all our partners for their unwavering support and innovative ideas. Your expertise, experience, and dedication have been invaluable. Thank you for your attendance. Now, over to Kaori.
Thank you very much, Fumiko. Next slide, please. As some of you know, a Global Health Innovative Technology Fund invests in open innovation, drawing on Japan's scientific pharmaceutical capacities and combined with overseas resources and networks, and create life-saving tools, including therapeutics for neglected diseases. Next slide, please. The creation of GHIT encouraged Japanese partners to work more with DNDi, and it's brought significant increase of partners and projects with partners in Japan and abroad. Next slide, please. So what value can we bring to our partners? We understand patients' needs in endemic countries and local context, which is important prerequisite to develop appropriate tools for patients. We have strong networks with MSF, research institutions across the globe, WHO, Ministry of Health, and we have the capacity to conduct clinical trials in the remote settings. By working with us, Japanese partners can contribute to global health through research, as well as to demonstrate their capacities in infectious diseases. They are able to understand local context and may develop a potential partnership in endemic countries. They may meet the expectations of their employees or stakeholders to contribute to global health, medicine access, and global commitment, including SDGs. We are looking forward to working with partners who are interested in contributing to research and development for neglected patients. Next slide, please. Let me talk a little bit about our 3 pillars of DNDi mission. The first pillar is to discover, develop, and deliver treatments for neglected patients, which are affordable, available, and adapted to communities. This is our core mandate and continue to be a very important mission. Second pillar is to support and strengthen research and development ecosystem in endemic countries in close collaboration with partners in low- and middle-income countries. The third pillar is to advocate for policy change to make more effective and equitable research and development and access in collaboration with our partners. I have discussed in previous slides the role of Japan office to find and develop partners from Japan. We also help connect researchers, policymakers in endemic countries with Japanese partners to strengthen art and ecosystem in endemic countries and support their fundraising activities. Another important role is advocacy. We work with policymakers and government to ensure more effective and equitable R&D and access to the fruits of science and for all people, no matter their income or where they live. Next slide, please. In terms of organizational strategy, we are in the middle of implementing a strategic plan from 2021 to 2028. We aim to deliver 15 to 18 additional treatments during that period and try to achieve a total of 25 treatments in 25 years since its inception. Next slide, please. As we mentioned before, DNDi have 9 offices in total, including DNDi GAPI office in South Africa, and this consists of diverse team members. As a global organization with offices and partners spread worldwide, fostering talent from various areas of expertise and settings, DNDi recognizes a diverse workforce and inclusive culture and are critical to the success of its mission and programs. Next slide, please. I would like to briefly touch upon the financial overview of DNDi. In 2022, 41% of our fund came from government donors. We included GHIT Fund here as they receive support from the government, followed by major private scientific donors such as Bill and Melinda Gates Foundation and Wellcome. Our funders include multilateral donors such as UnitAid, our founding partners such as MSF, and other partners, including the funding from Takeda Global CSR Program for NTD access. Next, please. This is a list of diseases or conditions we are working on at the moment. We are working on 6 NTDs: sleeping sickness, leishmaniasis, Chagas disease, filaria, mycetoma, and dengue, among 20 diseases WHO identified and NTDs, and other neglected diseases, including HIV pediatric formulation, hepatitis C, and pandemic-prone diseases. We are exploring several new areas as well. Today, our colleague Nelika will explain our efforts to develop treatment for dengue after this presentation. Next slide, please. This is my last slide to show you our latest R&D portfolio. We highlighted the project we work with Japanese partners, including pharmaceutical companies and academia. Our collaborations span from discovery to development stages, and we are very grateful for their commitment and partnership to discover and develop treatment for neglected patients. I hope that this seminar will trigger your interest and lead to future collaboration. Thank you very much. As I said in the beginning, if you have any questions, please write them in the Q&A session. And for the meantime, we are delighted to share 2 messages from our key partners to celebrate our 20th anniversary. The first message from Dr. Osamu Kuni, GHIT Fund CEO. GHIT has played a pivotal role as a funder for R&D for neglected diseases since its inception. The second message from Mr. Shinjiro Murata, General Director of MSF Japan. MSF was one of founding members and collaborators of various projects and in the field, and are one of our funders for DNDi.
Congratulations to DNDi on your remarkable 20th anniversary. We are very pleased to celebrate your milestone in the year of GHIT's 10th anniversary. DNDi has been a great partner for GHIT since we started 10 years ago, and we have been collaborating not only on research and development projects, but also in our commitment to global health. DNDi's extended networks have played a key role in bringing more partners to engage in global health, from farmer to academia, as well as local partners. Until now, GE has invested in over 20 research and development programs toward neglected diseases that DNDi participated in as a developing partner. 2 programs, drug development for leishmaniasis and mycetoma, are now in the clinical phase. We are excited about the bright future that DNDi brings to the global health community and patients in need through your important endeavors. We look forward to many more years of partnership, accelerating product development, and bringing more partners to the global health community for impactful outcomes. We would like to congratulate DNDi again for its extraordinary efforts and achievement for the past 2 decades. Thank you.
Congratulations to all of you on the 20th anniversary of DNDi. Over 20 years, the relationship between MSF and DNDi has remained very close, with a stream of people moving between 2 organizations, working hard in Grove to deliver better treatment for the people in need. MSF is an integral part of DNDi progress to innovate, save lives, foster sustainable solutions, and advocate for change. Internally, in October, MSF, we had a discussion and decided to renew the partnership agreement between DNDi and MSF. While MSF has faced a serious challenge in terms of access to medicines that has been hindered by attacks on medical care, we believe there are several areas of possible collaborations between DNDi and MSF, such as climate-sensitive disease, policy and advocacy, and our joint fight against NTDs. Once again, congratulations on your 20th anniversary. MSF is happy to continue discussions on our possible collaborations. Thank you very much.
Thank you for encouraging messages from our partners. Let me invite my colleague, Professor Nelika Malvaj, DNDi's Dengue Project Head and recognized leader in international dengue research, to present global dengue efforts and DNDi's progress in dengue treatment development. She's a professor at the University of Sri Jaruwanadabla. She previously was the head of the Department of Immunology and Molecular Medicine, where her research focuses on dengue was to find out the therapeutic targets, notably mediators of vascular leak, the role of antibodies in disease pathogenesis, and correlates of protection in dengue. Nelika holds a Bachelor of Medicine, Bachelor of Surgery, who graduated from University of Colombo, Sri Lanka. She also holds a membership of Royal Colleges of Physicians of the United Kingdom and a Doctor of Philosophy from University of Oxford. Nelika is an academic visitor at the University of Oxford and has ongoing collaborations on dengue. Nelika, the floor is yours.
Thank you so much for that introduction. I'm most honored to talk at this. Let me see. I mean, I don't know if the right screen is being shared. So just to take you through a little bit about dengue, why DNDi is focusing on dengue and why it is important for all of us. So I'll take my pointer out as well so that I can point. Okay. So I mean, dengue has been increasing, rapidly during the last 30, 40 years. And every decade, the incidence doubles. So from 1990 to 2017, the global infections increased from 23 million to 104 million. So that's a very massive rise of dengue. But more than just a rise in the incidence, the age-stratified deaths increased, and the disability-adjusted life years also increased by 109%. So that is a massive increase. And 70% of the burden of dengue is in Asia. However, when it comes to deaths, for some reason, you have more deaths in Asia compared to Latin America, which is something else that we need to find out the causes of this. Now, after 2 years or 2.5 years of COVID affecting us, 2020, 2021, and 2022, with the relaxation of, the COVID-19 social restrictions and travel, dengue really started, increasing since mid-2022. And in 2023, dengue has been a particularly bad year for dengue. There's been massive outbreaks everywhere in the world, from Latin America to Asia. And many countries not only have reported record number of cases, they have recorded record number of deaths. So for instance, in Bangladesh this year, so far over 1,500 people have already died in Bangladesh. And similar numbers and similar burden were seen in many Latin American countries as well. So to answer the question, why is there a sudden surge of dengue in 2020, 2023? It is not sudden. In 2019, because of the huge burden dengue was causing globally, WHO named it as one of the top 10 threats in global health in 2019. Then, of course, we know that in 2020 to mid-2022, everybody was involved with COVID. And fortunately, because of certain reasons, social restrictions and so on, which I won't talk about today, the incidence of dengue was very less in those 2.5 years where we battled with COVID. But as I said, when the COVID restrictions eased, traveling started, things have been really bad for dengue. And of course, this gradual rise in dengue is due to many reasons. One important reason is climate change. So this increase in temperatures, erratic rains, all of these contribute to dengue. So for instance, last year, Pakistan had a really bad dengue outbreak after the Pakistani floods. I hope you remember. And in Peru, again, it was pretty bad this year. And that was after rains after El Nino. And also in Asia and in Latin America, what has happened, there has been unplanned urbanization, overcrowding, and population expansion. And all of this has led to the massive rise in cases of dengue. And as I said, dengue is a climate-sensitive infection. So here in 2019, as you can see, because of the high temperatures in the tropics and subtropics, you do see dengue mainly in these areas. But and on a few months, you might have 1 or 2 months, you have dengue in other areas. But in 2050, you can see because of the rising temperatures, you get more and more dengue, higher transmission in the dengue endemic countries, and dengue spreading to other countries. And in Europe this year, and also in some states in US, we did see endogenous dengue transmission, or in other words, dengue transmitted locally. So all this time, the dengue cases, the few dengue cases that you did see in Europe, US, South Korea, possibly Japan as well, was due to travel-associated dengue. And travel-associated dengue has become a really big problem. Some countries are reporting really large numbers of travel-associated dengue. But also, because of climate change, you do see an increased number of dengue cases in countries where there was no dengue at all previously. And these are just some scenes. The one on your, this is a hospital in Sri Lanka. This is in India. And there are, apart from the incidence of dengue increasing, there have been other things also happening in the dengue scenario, epidemiology, that has certain implications. So although people call dengue a mild illness, if you actually go back, in Asia, I mean, many of the Southeast Asian countries experienced dengue in the 1950s, and the mortality rate or case fatality rate was more than 10%. But with better understanding of dengue, we have managed to cut down the case fatality rates. And this is by finding out who is going to be developing these complications, by monitoring anybody with a dengue infections on a daily basis, and timely fluid management. Because what happens in dengue is fluid leaking out of your capillaries, so your blood pressure falls. So how it is treated is replacing this fluid, because there is no treatment for dengue. So obviously the fluid replacement needs to be individualized. And this is terribly difficult when you have large number of patients. So when dengue initially started, it was a predominantly childhood infection. But as you can see, this data from Thailand, which is the same for everywhere else in all dengue endemic countries, dengue is now affecting all age groups. So dengue hemorrhagic fever, although was predominantly seen in children in the until 1980s, has now shifted to involve all age groups. And of course, the population has started aging in many countries, but this is disproportionate to the increase in the age of population. So we see more and more cases in adults now. And this brings us to many other problems. So when you have more infections in adults, you have more infections in pregnant women. You have more infections in elderly and in those with comorbidities like diabetes and obesity. So diabetes is not common in children, but especially in many countries, we have an epidemic of diabetes and other diseases. So dengue pregnancy is terribly, terribly dangerous. So dengue hemorrhagic fever increases maternal death by 450 times compared to a pregnant woman without dengue. And this is data from a large study conducted in Brazil. And dengue in pregnancy is also associated with fetal complications, stillbirth, preterm delivery, fetal distress, and miscarriages. And when you have more severe dengue and anybody with these comorbidities, the WHO advises you to get admitted to hospital. So just to let you know a sad fact, in 2017 in Sri Lanka, we had the largest ever dengue outbreak so far. And the #1 cause of maternal deaths or the deaths in pregnant women in 2017 was due to dengue and no other cause. So an argument brought by many individuals is, isn't dengue mild in most? So just to again let you know, so this is data from Indonesia. As you can see, in the 1960s, the case fatality rate was pretty high. Okay, it was more than 40%. And the case fatality rate has gradually declined in Indonesia, like in many countries, although the incidence has gone up. And but as you can see, in many countries in Latin America, although the goal is to achieve a case fatality rate of less than 0.05, many countries have case fatality rates more than that. And in Malaysia, again, yes, the incidence has gone up, but the case fatality has gone down, but it's still not satisfactory. So many countries do have case fatality rates of over 0.1%. So dengue is not a mild illness in everybody, and the only reason why all countries have managed to bring down these case fatality rates is by doing intense monitoring of patients who have dengue. They have to visit a doctor every day, have their blood pressure checked and all the vital signs checked, and their blood taken every day to see who will develop fluid leakage. And when you have thousands and thousands and thousands of patients, this is extremely difficult. So it's not just about being mild, it's about the cost of dengue. So initial study said that the global cost of dengue was 8 billion. This is the annual cost of dengue, which is far more than rotavirus, gastroenteritis, cholera, Chagas. But then a later study in India done by, Donald Shepard was the lead author of this study. But later when he did a study in India, in 2016, what they found was this $8 billion was a gross underestimation. And when the costs in India alone in 2018 was $1.71 billion. So this is direct and indirect costs. And there is this large study done in Asia of how much episode of dengue costs. And outpatient cost is around $3.8 to 1,338, because in different countries, the cost of healthcare is different. Hospitalized, again, it's different. And fatal dengue, of course, costs a lot of money. But it's not just the direct cost of hospitalization, but the indirect cost. So this is another data from another study in Thailand, where somebody who has mild dengue, which is dengue fever, loses 8.4 working days on average. Somebody who has dengue hemorrhagic fever loses 9.7 days on average. And somebody who develops shock loses 12.3 days in average. So this is a huge loss of work and a huge economic cost in a large proportion of the world. And given that many of the dengue endemic countries, many of individuals are daily wage earners, they don't have paid medical leave. When they do have dengue, their families go hungry because there's nobody to put food on the plate. And so how can we face these challenges? Of course, because of all these things, health ministers have to resign, and high fatality rates, a lot of things are happening. So the only measure that has been done so far is vector control. So since the 1950s, because dengue is spread by Aedes mosquitoes, it has been looking for breeding sites, destroying breeding sites, and of course, this chemical fogging to destroy mosquitoes. So many mosquitoes have become resistant to it, using insect repellents, covering your skin so that you don't get bitten by mosquitoes. Despite all these intense measures, I just showed you the data that dengue is increasing. And there are newer dengue control methods, like the Volvivacia program and so on. But again, these are very expensive, and vector control alone is not unlikely to control dengue. Of course, we have dengue vaccines. So the first dengue vaccine was from Sanofi, which was initially registered in Mexico in 2015, and subsequently in many other countries. And it was given to all children in Philippines. And after it was given to all children in Philippines, then the manufacturer released the results showing that in those who did not have dengue, who were vaccinated with the Sanofi vaccine, they tend to get more severe disease. In other words, people who received this, children who previously did not have dengue, when they received the vaccine, they were more likely to develop severe disease. Now, so of course, that vaccine didn't do much good, and nobody actually uses that vaccine anymore. So now we have got a new vaccine developed by Takeda, TAK-003. And so there are many publications out there of their data. The phase 3 trials have not ended, coming to the end of the 5-year trials. And the WHO Experts Committee on Immunization met in September 2023. And these are the guidelines they have given. So this Takeda live attenuated vaccine demonstrates efficacy against all 4 serotypes in baseline seropositive children. So in children who did previously have dengue, it does demonstrate efficacy against all 4 dengue viruses. There are 4 dengue viruses. In baseline seronegative children, in other words, in children who've never had dengue before, they only protected against serotype 1 and 2. And in baseline seronegative children, the vaccine did not demonstrate efficacy against symptomatic disease against serotype 3 and 4, and had no efficacy against hospitalization due to serotype 3. And of course, for 4, there were not enough sample size, so it could not be evaluated. The potential risk of enhanced disease due to serotype 3 and 4 in seronegative vaccinated children cannot be ruled out. So the WHO is being careful here because actually the data shows that the vaccine does not prevent hospitalization. I mean, no efficacy at all. The means are in the minus. So whether this vaccine protects or actually, like the Sanofi vaccine, whether it enhances infection is something that needs to be investigated. So the SAGE recommends that the vaccine to be introduced in settings with high dengue disease burden and transmission intensity to maximize the public health impact and minimize potential risk in seronegative persons. So in other words, to vaccinate children or people at high disease burden and transmission settings. So in such a setting, children would at least have had one dengue infection. So in short, Takeda dengue vaccine seems very promising in reducing the burden in high transmission settings, where the majority have already had at least one dengue infection. So just a bit about the Wolbachia mosquito program, because I did say that, so far we've only been using mosquito vector control methods. So in the Wolbachia mosquito program, what happens is there's this bacteria that infects the Wolbachia mosquito, and then when the female mosquitoes are infected with it, the eggs don't hatch. And of course, this is looking very promising. So for instance, studies in Indonesia and in Colombia have shown that the dengue rates have dropped after release of modified mosquitoes in Colombia. This is absolutely fantastic news. So in Singapore also, this program has happened, but in Singapore, they're a little bit more cautious, saying 300 million mosquitoes released in Singapore. That's a large number of mosquitoes, but it's not a silver bullet to deal with dengue. So it's very costly, and you have to keep on releasing large numbers of these mosquitoes to sustain what the Wolbachia program does, bacteria does. And I thought everybody might be interested in this. So if you can just look at where my pointer is showing. So this is data, 50 years data from Singapore. So this is the number of mosquitoes in a household, ED's house index. So in the early 1960s, okay, 1966 to be exact, this Singapore started this vector control program. And because of that, very aggressive vector control program. And because of that, the number of mosquitoes in a household gradually declined. As you can see, so in a household in Singapore, there are less than 5 mosquitoes. See, it's been very effective. Their mosquito program has been very effective in reducing the number of mosquitoes. Okay? And this is the number of cases of dengue. So although the number of mosquitoes have declined, the number of cases of dengue has increased. Okay, so from 1966, the mosquito house index from 48% has declined to 5% and to around 1% in the 1990s. However, paradoxically, the number of reported dengue cases and outbreaks has increased since 1990s. So vector control, or in other words, reducing the mosquito population is not just going to solve the dengue problem. I won't go on to explain why you have this, reciprocal thing, but when you reduce the number of mosquitoes, why do you get increase in number of dengue cases? I think this is not the forum. We'll have to go into a lot of details of dengue epidemiology to understand that. But this is just real world data, a fact that the number of mosquitoes decrease, but the number of dengue cases increase. And if you look at just about clinical trials for dengue and COVID, of course, everybody had a huge issue with COVID, but of course, the COVID mortality rates have declined very much in many countries. In Asia, the case fatality rates are less than 0.01%. I just showed you dengue case fatality rates, which is more than, 0.1%, or 10 times more in many countries. However, there are 2,079 trials for COVID. No surprise. I mean, we had to act, otherwise all of us would have been in trouble. Currently, there are 172 trials actively recruited and 782 completed. But for dengue, there were 92 trials. So when I say 92 trials, this is not just drug trials. These 92 trials and these 2,079 trials includes vaccines, drugs, and trials on vector control. So actively recruiting, there are only 4, active and not recruiting 2. So right now, there are only 2 trials happening for drugs. So only 2 drug trials are actively happening globally for dengue. So this is just a comparison of mortality rates and dengue compared to COVID. And to actually answer the question, why aren't we focusing on dengue? So this picture is from Sri Lanka, and this is a dengue ward. Okay, so many patients just coming with dengue patients, and then you don't know who is bad, who is not bad. You have to find out who is leaking. It's a terrible scenario. So there's a misconception that dengue is mild. So and the reason actually we have to cut down the case fatality rates is trying to find out in a busy ward like this who is developing complications and leaking and who is not, so that fluid is given. And there's a misconception that it costs too much to develop a treatment. So in India alone, we are spending $5.7 billion annually. Even if you put a really tiny fraction of that, like 1% of that to develop a treatment, what difference can we make? And can we just keep on replacing fluid as a treatment for dengue? And don't we need drugs? So DNDi, along with the Dengue Alliance, we have come up with a strategy to find answers. So right now, there's a serious problem in identifying patients with dengue, and the clinical features of dengue, especially during early illness, are very much like COVID, influenza, leptospirosis. So you can't really diagnose patients with dengue. So we do need proper diagnostics. And because, as I mentioned, we don't know who's going to develop leakage, you need to monitor everybody. So we need prognostic markers to find out who is going to develop severe disease. And of course, we need effective, safe and effective drugs to prevent people needing hospitalization. And in order to do this, DNDi has formed this Dengue Alliance. So DNDi is yet another partner in this Dengue Alliance. And we have 6 partners: Mahidol University from Thailand, PHSTI from India, Ministry of Health Malaysia, Fiocruz and UFMG from Brazil. So together, we are trying to develop a treatment. So there is a preclinical working group looking at repurposing, doing the preclinical assays for repurposing drugs for dengue, and also engaging with pharma to see if any of their compounds, new chemical entities, can also be evaluated for dengue. We have a clinical working group from members of all these institutions and additional international experts to design clinical trials. So the preclinical studies and the clinical trial design are going hand in hand. We also have a translational working group working on diagnostics and biomarkers. And this whole alliance is governed by a joint steering committee with a rotational chair, so that decisions can be made and we can move forward. So it is not just a DNDi initiative. This is an endemic country-led partnership to find solutions for something that is affecting them. So, so we've had 2 in-person meetings of the Dengue Alliance now. The first one in India, early February this year, and in early November in Rio, Brazil this year. So thank you. That's all from me, and I'm most happy to take questions. Just want to stop sharing.
Thank you very much, Nerika.
Trying to figure out how to stop sharing. Figure out. don't know how, don't see the, don't share button, stop share button.
You did.
Okay, have I stopped sharing?
Yeah.
Okay, okay, good, good, thank you, yes.
Thank you very much, Rika. While we are waiting for any questions from the audience, I'm going to start with my question. Is it going to be okay?
Yes, yes, there are questions from the audience, but yes, please go ahead. Yes.
Okay, I'm sorry. Okay, let me just go. Okay, first question. What is the target population for the treatment?
Yes, so
And yes, please. And maybe the second question, hello. Would we be able to have a collaboration for the dengue treatment program? Very specific question. Maybe you can just address two questions first. Yeah, thank you.
Yes. So the target population is everybody, because we know that infants get sick from dengue and die. We know that children get dengue and die, and of course adults as well. Currently, the mortality rates are more in adults because you have more cases in adults, and also because when children are sick, parents are worried, so they run with their kids to the hospital. When adults get sick, they try to finish their work and don't prioritize their illness. So, so adults tend to die more frequently than children because they neglect themselves. So the treatment is everybody, including pregnant women and children. So the treatment has to be very safe. And about collaborating for a treatment, I mean, definitely, I don't know who is asking the question, and definitely, I mean, we would very much want to collaborate for finding a treatment for dengue.
Thank you very much. Probably while others are thinking about questions, maybe I'll just ask one question. What is the immunological differences between those who are infected with dengue fever and those who do not develop the disease?
That's a $1 million question, I would say, or $1 billion question. So in other words, for vaccine trials, this has been the main issue. If you take something like measles or chickenpox, you see, we know if you have antibody levels to a particular amount, then you're protected from, you're completely protected. So if you give a measles vaccine or a chickenpox vaccine or a hepatitis B vaccine, you know, okay, this person has achieved this much of antibody levels and is protected. For dengue, we don't know. And I'll tell you, and so for dengue, we don't know what sort of immune responses you need to be protected from dengue. So this is the main issue for vaccine companies, manufacturers, to develop good vaccines. And also when it comes to drug development, we don't understand really what causes this leakage, capillary leakage, and who actually develops severe dengue. I mean, can you predict it? So the reason why we don't know these things is there has been very poor funding for dengue. Dengue has not been a priority. It's only now people are sort of, you know, high-income countries are putting a little bit of, you know, focus on dengue because they are getting affected in summer months, and also because of more travel-associated diarrhea. I mean, all this time it was infection of people living in countries like me in Sri Lanka. And of course, as you know, we don't have much money to invest in these things. So these are $1 billion questions that people don't know answers to.
Thank you very much. And I think the second question that we had, actually, somebody who wants a collaboration with us in dengue treatment program. How actually can we take this conversation further? She or he would like to know, how can we start collaboration? What is the actual suitable steps for collaboration? Maybe
so if you can have a meeting,
please answer the question.
Yes. So if we can have a discussion with him or after this event, and we find a suitable time, then we can discuss how to take this forward. We are very, very happy to have a discussion, and very, very happy that he's interested.
Thank you very much. It seems, I think we have, you have answered at the moment all the questions. Maybe I will just have another question to you. Yeah, thank you very much. Is dengue resolved in the elderly as COVID-19? Maybe that's also another
Yes, so the
important question.
Yes. So the risk factors for severe dengue and COVID-19 seem similar. So for instance, we know that elderly get severe COVID and severe dengue. We know that pregnancy is a risk factor for severe COVID and dengue. But the thing is, like, as you in endemic countries, when you get older, people already have had dengue several times as children. So infection is not very common in elderly with dengue because they've already had dengue several times. So most of the infection is in young. So when I say you have more infection in adults, it's actually adults between the age of 20 to, let's say, 40 years of age. That is the median age, which is the reproductive age, sadly. So you have a lot of infections between, let's say, 20 to 45 years. But in really elderly, dengue is severe. But fortunately, we don't have a lot of infections in elderly because they've already had so many infections as in their childhood and as adults.
Thank you very much. Since we are still waiting for other questions, maybe I will just share with the questions we receive quite a lot for DNDi Japan. Maybe the first question is, it's about the intellectual property. And a lot of people think that the IP is an obstacle when working with pharmaceutical companies. How do we work around it? This is a question we receive a lot. So our basic stance is that for us the goal is to reach access to low cost and easy to administer drugs, and we will not agree unless these principles are guaranteed. We will not ask you to give up all your IPs. We have an IP policy, and the policy is based on 2 guiding principles that inform all contract negotiation with partners. The 2 principles are the need to ensure the drugs are affordable and accessible in an equitable manner to patients who need them, and desire to develop drugs as global public goods whenever possible. So DNDi also publishes model contracts or templates of collaboration and licensing agreements, and that it signs with public and private partners, and including pharmaceutical companies. So these templates are in public, so people who are interested, we can also share the link of the document. This is one question. But also another question we received from the partner is that, does DNDi or DNDi Japan accept donations from individuals? Yes, DNDi accepts donations from individuals, which can be made online at the DNDi website. For questions specific to DNDi Japan, please contact us at the email address listed. Contact us on our website of DNDi website. Please note that DNDi Japan is not tax deductible organization under the Japanese tax system. But we are able to accept the individual donations. It seems we have no more questions. I think we will proceed with the program. Thank you very much, Nerika, for your presentation.
Thank you so much. I'm very much honored.
Thank you very much. As we close to the end of the seminar, we are delighted to share a message from Dr. Ayano Kunimitsu, member of the House of Representatives and Secretary General of NTD Parliamentary League.
Thank you, Nakatani-san, for your kind introduction and very warm welcome. Good afternoon and thank you for inviting me to DNDi's 20th anniversary webinar today. I'm really pleased to have this opportunity to address you on the importance of Japan to engage in research and development for neglected disease. I studied at Nagasaki University School of Medicine. There, I became interested in public health in low and middle-income countries, including issue of tropical disease. My experience working in endemic area led me to my current position as the Secretary General of the NTD's Parliamentary Leagues. Dr. Matsumoto, former Minister of Foreign Affairs, served as chairman. We are working toward the day when neglected tropical disease will be taken care of. Although the number of members of the Diet was small as a Benin, we gradually expanded the number of members and appealed the necessary effort on NTDs. We also repeat our request that the Japanese government will continue its effort to address NTDs and achieve universal healthcare coverage. Together with young advocacy groups. One of the major results of this year's activity is that we are able to achieve the government's contribution of about $200 million to the Z-HIT Fund at the G7 Hiroshima Summit. It's held in May of this year. In this sense, I believe that there is a momentum for NTDs. I'd also like to support the implementation of the Nagasaki Outcome Statement, which was delivered for the G7. It builds on and reaffirms the Kigali Declaration, which is a high-level political declaration that is mobilization, political will, community commitment, resource and action, and securing commitment needed to end suffering caused by NTDs. Based on these momentums, I'd like to advocate for Japan's contribution and increased presence in NTDs and its importance of sustainable investment of research and development for NTDs. We look forward to your continued understanding and effort. Thank you so much.
Thank you very much for Dr. Kunimitsu for her passion and commitment to NTDs and continued support to develop treatment for neglected patients. We would like to conclude this webinar with a message from Dr. Luis Pizarro, Executive Director of DNDi.
Hello, DNDi partners, DNDi's friends. It's a pleasure for me to be with you today through this video to celebrate the 20th anniversary of our organization with all of you, because the relationship DNDi has with Japan, it's a very long and very close relationship, of course, with Japanese government first, the different ministries, JIHID, that has been absolutely key in DNDi's development, but also actors in the academia sector, in Tokyo, in Nagasaki, and actors in the pharmaceutical sector, Eisai, a strong partner of DNDi, Shionogi, Takeda, and others. Together, we have developed very important treatments for mycetoma first, a big achievement of our collaboration, but also in other diseases like Chagas. And I had the opportunity this year to spend some time with you. I would like to thank you for the warm welcome you gave me and repeat how impressed I was by the ecosystem you have built in Japan. I would like also just to finish sharing with you a very nice history. The DNDi was awarded by the Asturias Prize this year. This is an important prize in Spain and in Latin America. And we were very lucky to be with one of your most famous writers, Mr. Murakami, and we had the opportunity to share with him the strong collaboration we have built with all of you. He was very impressed about that, and who knows, maybe in the future we'll have the chance to read something from Mr. Murakami. So let me conclude saying very much welcome to this webinar. Thank you very much to all of you for the engagement on neglected diseases, and DNDi will be very, very happy to continue this collaboration in the future. Thank you very much.
Thank you again for taking your precious time to attend this webinar, and we hope that we could trigger your interest in working with us. You can actually see the link to the longer version of the DNDi video in the chat. Thank you, and we hope you will enjoy it. And thank you very much again, and have a great morning, great afternoon, and evening.